Good morning, my name is Alexandra Lansky. It's my pleasure to be here this morning with Dr. Udo Hoffmann from the Mass General Hospital in Boston. We're going to be discussing your clinical trial, ROMICAT II. This is a study of cardiac CT versus alternative triage strategies in acute chest pain patients in the emergency room. So, Dr. Hoffmann, can you give us a little bit of background on your study and why this is so important from your perspective in the emergency room?
Yes, of course. The patients presenting with chest pain is one of the most frequent or the most frequent admission that we see, and as a result emergency rooms are overcrowded. The reason why those patients often stay 24 to 36 hours is because the initial triage usually does not allow to reasonably rule out myocardial infarction. And so as a result, over the last years, rule-out MI protocols have been established that usually involve admission to chest pain observation units or the hospital, involve serial EKG and biomarker measurements, but then also usually a functional test to rule out CAD as a course for chest pain. Now, similar to PE or CT scanning for pulmonary embolism, CT of the coronary arteries directly visualizes the disease that is most often responsible for an acute coronary syndrome. And we, a few years ago, did a study, ROMICAT I, which was an observational study, which showed that if you rule out coronary artery disease, you have a very high negative predictive value to also rule out ACS, in fact 100% in those studies. Those studies also enabled us to hone in on the population where tests like cardiac CT, which comes at a certain cost and risk, may be most efficient, and that is a population that is from 40 to 74 years of age and has no history of coronary disease. So we want to take advantage of the high negative predictive value of CT.
And can you give us sort of an overview of your trial design, how you did this, and maybe highlight some of the outcomes that you found?
So we really want to make this a test about how does CT affect decision making. So it was not a trial that put two tests head-to-head to each other as it has been done previously, but it's more like, think of it as two care strategies or management strategies. One that involves CT as early as possible, that we call the CT arm, and the other one, the standard devaluation, where physicians had the choice to do whatever they feel is best for the patient. So they could do functional testing or no testing. So we randomized 1,000 patients at 9 US centers to one of those two strategies, and then we basically observed. The centers were chosen being academic and some non-academic centers in a way that they reflect, in our point of view, a very pragmatic and generalizable group of centers. So the results of the trial, we hope, are useful not only for top academic centers, but also for centers that community hospitals, and really should reflect what the effect of CT would be. Mm-hmm. So from the randomization, we basically observed what the patients, how the patients did, what tests were being done, when they were discharged. And then we did a 28-day follow-up to see whether there were any subsequent events or testing.
And so can you just give us the key take-home messages from the studies and your findings?
Yeah, so the primary endpoint of the trial was the length of hospital stay, and the trial was positive in a way that CT reduced the average length of hospital stay by 8 hours, from 31 hours to 23 hours. Another metric that is probably more a process metric is one of the secondary endpoints is the ED discharge rate. And in the CT arm, there were 4 times more patients directly discharged from the ED, 48%, as compared to the standard of care arm. So what we've seen is really a shift in that patients whose chest pain was not related or to an acute coronary syndrome were identified earlier and could be discharged earlier. In our safety endpoints, we saw that we did not miss an ACS. So despite that patients were discharged much earlier, there was no missed ACS, in fact, in either arm. So it's a 0, very 0, which is very important because you don't want to improve the management at the cost of increased events. What we also saw is that the costs of care, which is a very important component here, if you think of the high number of patients we're talking about nationwide, was similar between the two arms. That is in contrast to other analysis of Medicare data who have shown much increased diagnostic testing and subsequent costs after CT, which is certainly a concern. What we have seen is that in the patients where CT detected disease, there was increased diagnostic testing. But I think our careful selection of our population struck the balance so that we, on the one hand, could take advantage of the high negative predictive value, send a lot of patients home early, but then on the other hand, spend more resources on the patients who have disease.
So in terms of, the whole triage and trying to expedite that, and again, speaking to the negative predictive value, clearly that's what we want to be able to do when we assess these patients. Does this apply to all patients? Are there certain patients with prior bypass, patients with known coronary disease, have had interventions, etc., where this may not be an optimal approach in triaging them?
That's a very good question. So the patients in our study did not have known CAD. That was an exclusion criteria. We know that in those patients, CT right now would not be useful. Right. We also choose not to have patients above the age of 74 because there the prevalence of coronary artery disease is just so high that almost everyone you will image will have coronary artery disease, and the strength is to have in our case about 50% of patients who had no disease at all, and I think that's an important very important to see the population and match the population with the strengths of the techniques.
So tell me this, do you think this is going to impact how we triage our patients? Is this trial, it's obviously a very large study, is it going to influence our whole approach to patients and the evaluation of patients in the emergency room?
I think it shows that if you even if you're not a super expert CT center, that you can use CT, and if you use CT, you are able to to include it in your care without that you harm patients in a way that that you miss ACS, and without that you increase costs, but you can rule out patients earlier and get them out of the ED quickly. So if the collaterals here we did not assess so far, which is how does it impact other patients? What's the benefit of patients who now can actually be seen in the ED? And that's one of the next, that's a more complex problem, one of the next studies we will be doing. But I think it shows that it is a viable alternative to standard of care.
Well, I want to thank you very much for joining us today, and congratulations. That's a large trial, very well designed, and very important contribution. So thank you very much, Dr. Hoffmann, and that concludes our interview.
Thanks for having me.